Have a good day, all the participants. I think by now you have understood the importance of palliative care. And today we are going to talk how a palliative caregiver should interact with the patient in his first visit. It's very important. Suppose a doctor has referred a patient. Most of the time the social workers, NGOs, and they are running the palliative care center. Sometimes it is in the hospital also with the anesthesia department, but mostly these NGOs and societies are running a palliative care center. So a social worker visits to the patient. This is very important, and he is the bridge between the patient, his family, and the whole team of palliative care, which includes a doctor, a nurse, a psychologist, a social worker. Everybody is included in that team. But how he is going to behave, this is very important, and I'm going to focus today on that. The salient features to initiate the palliative care. What is palliative care? All of you know. WHO guideline recommended holistic patient care that focuses on total well-being of the patient. But here the health services are patient-centric to improve the quality of life by managing the disease-specific symptoms. What is those symptoms? Pain is the main issue, fatigue and weakness, sleep disorders, insomnia, and the digestive issues. There may be constipation, there may be loss of appetite, there may be diarrhea, anything can happen. So these four pain symptoms are very important in palliative care because elderly people have these kind of things, but if he is suffering with a chronic disease, it is more intensified. So how it is addressed? Psychological and spiritual need, psychological support, social concern, spiritual well-being, and family and caregiver support. All the four things are needed. So why palliative care matters today is also important. First of all, you know that many people don't know about palliative care. Its awareness is very poor. But those who know, they are offering, but it is very expensive. So we will come to the next slide, what to do in this case, how to bring awareness, how to bring in the mainstream, health stream. These are the issues we have to talk about. But why palliative care matters today? Because rising burden of non-communicable diseases. NCD is going very high, like metabolic syndrome, and this covers hyperlipidemia, fatty liver, whatnot, obesity, diabetes, cancer, cardiovascular diseases, blood pressure. These things are the regularly increasing in the whole world, in the whole society. All the countries are facing this problem. India has a great major problem because it has been considered it is a hub of diabetic patients. Then when diabetes will be there, then diabetic complications will also be there. Diabetic nephropathy will be there, diabetic neuropathy will be there. Many things, retinopathy may come. So the patient is living, but with a comorbidity. His quality of life is not good. He is adding years to the life, but not life to the year. Life means healthy life to the year. The aging population with multi-morbidity. Our average age has increased now. In India, it is 72 years. Earlier, it was less. But if you are living, but with a morbidity, it is not good. We want, Ayurveda says, swasthasya swasthya rakshanam, aturasya vikas prasannam cha. Means healthy man should remain healthy. What do you mean by healthy? All the 5 sense organs should be active, all up to 100 years of your life. That is called the healthy life. Not only you are living with all sense organs intact. Then late stage diagnosis is still common in low resource setting. This is low and middle class countries. You know that diagnostic part is very poor. Population is very high. Everybody is not going to the hospital. So the early diagnosis is not being done. When the diagnosis takes place, the case is too late to manage. So prevention is better than cure is the slogan of WHO. And I also told you, Swasthya Swasthya Rakshanam. Prevention part is very strong in the society. But what is happening? Because of the lack of proper diagnostic tools and lack of the willingness of the society to go to the doctors to get the annual health checkup, they're not doing it. So it is very late. The late stage diagnosis is the main problem. And over medication also affects the quality of life, because every drug has some effect. For everything you are taking a medicine, you are not changing your lifestyle, but you want to be healthy, you want to be at your work by taking the medicines. These medicines have their side effect. One should avoid as much as he can. That's why the naturopathy, panchkarma, lifestyle modification, these things are now coming up very well. After COVID, I think the whole world has realized the importance of lifestyle change and all these things. So now a collaborative, integrative model enhances the effectiveness of the care, palliative care. What is a collaborative, integrative model? So capacity building through training and education. But we don't know, in India, the Ayush healthcare system is a legal system and along with the allopathy system. But people don't appreciate each other. They don't understand what is the basic. Ayush people know little bit of allopathy, but allopathy people don't know at all about Ayurvedic concept. This gap is there. It has to be fulfilled by some proper training, some orientation program, and integrate the allopathy and traditional medicine. In China has done a wonderful job. TCM, traditional Chinese medicine and allopathy has been so nicely clubbed in the Chinese government hospitals, in the private setup, that they are doing excellent. That's why the traditional Chinese medicine has been accepted as a medicine system even in US. But in Ayurveda, it has not grown up to that level. Scientific validation has not been done. This is part of lacking. And then development of community-based models and capacity building through training and education. Capacity building is fine, but community-based models. What is community-based model? Where the resource person and the society both are participating in giving the training. So the barriers and challenges in implementation: poor integration across medical system, non-willingness of proper training physician to collaborate with the palliative care unit. Palliative care is a special branch, but the treating physician should also appreciate it. They are not appreciating that much. That is the problem. Lack of policy to include palliative care under the health insurance policy. This is the government who has to think. I think in the US, I have come across, I'm not sure, that after the heart attack, the insurance covers the 7 days physiotherapy. They're not using the word palliative care. They're using the rehabilitation for 7 days in the hospital, not at home. So at least in a heart failure patient has been included. But palliative care should also be included, say, in the cancer patients. A lot of problem is there. In the paralytic patients, hemiplegia, a lot of problem there. It has to be there. Policy includes. And limited awareness among patients. Patients feel that, look, I have gone hemiplegia or paralysis, I'm not going to be cured. They get hopeless and they lose their interest in their life. The awareness is on. They should be brought to notice. Still, there is a hope by using the palliative care. This awareness is very lacking in society. And financial burden of the family, that is very important. Financial burden is there. Somehow, there are many government schemes are available, but people don't know. They don't utilize it. We have to work on that part so that whatever facility is present in the society by the government, by the NGOs, that should be transferred to that suffering patient and his family to reduce the financial burden. Lastly, lack of trained palliative care professionals. This is also very important. This course which you are attending, this is with the objective to give more trained professionals in the society so that this can be given. Then urban-centric palliative services. Most of the services are localized in the cities, not in the villages. So if the more professional will be there, they can start working in the village, suburb area. That's also very important. So ultimately, take home message, our strategy would be to overcome the structural, cultural, and systemic barriers. No demographic challenges in the palliative care. More than 70% Indians' deaths occur at home, often without supportive care. 140 million elderly, this census 2021 projected to have doubled by 2050. So the palliative care need will be very high. Professional trained palliative care giver should also increase accordingly, because this elderly people will going to very high in number by 2050. NCDs are gradually increasing in society due to poor quality of life, lack of early diagnosis, and low awareness about how to change their lifestyle or for their prevention. And gender issues, women caregivers are fewer in number in the society, so the elderly women are underserved. This is also very important issue. Male people are coming. So I think our government is encouraging women empowerment. So some women should be attracted for professional palliative care training also, so that our elderly women in the society can also be given good service. So pediatric palliative care is also being neglected. At present, I would summarize that the elderly men are more aware and getting palliative care at the moment. This is a challenge we have to look at. The planning must be tailored to population structure and disparities. This is important. This is a government job, and our being a society, being educated member of the society, it is our duty to keep on posting the government, the policy makers. Okay, look, this is the problem in this society and you have to look into. Slowly the momentum will take place. If you go to the parliament, it will be approved and then it will be included. It cannot be done in one day. You have to work continuously. The next slide is what is patient-centric palliative care. I told you it is not the one method for everybody. Every person has a subjective method of treatment. Every patient has a different genetic constitution. In Ayurveda we call Prakriti. Prakriti is different, so his lifestyle, his response to the diet, his response to the medicine, everything has a customized. That has to be taken care, which determines their likes and unlikes and physical needs. Okay? And besides the presence of different NCDs, somebody will have cancer, somebody will have heart disease, somebody will have something else, but all are NCDs. So depending on the patient prakriti, genetic constitution, and the presence of disease, morbidity, you have to decide the model of palliative care to a patient. Okay? What is the core goal? The goal is the same, to improve the quality of life, to manage the physical symptoms like pain, fatigue, digestion, sleep, to address the psychological, social and spiritual concern, and to include the family caregivers in the care plan. The goal is the same, but the method of applying psychological tools, social tools, spiritual tools, this will vary from man to man. So when treating a physician should refer, this is also a $1 million question. You are in a hospital being treated by an endocrinologist for diabetes and its complications, but he is not referring his patient to the palliative care unit. When he should refer, that is a very important question. Most of the time, people feel that when the patient comes at the end of his life, then they refer it, which is not true. In the earlier slide, I have shown you, there is a graph. When you diagnose a patient with a chronic disease and you can foresee that the patient is going to have complications if not managed properly, then you should start preventive measures to prevent the complications. By the treatment is fine, but also get him in touch with the palliative care. So what I mean to say, goal of the referral is to enhance the comfort, dignity and decision-making support. This is the goal. And the treating physician should have this goal, then only he can refer. Otherwise, he will not refer, and which is the true current practice in the society. The early referral means following are noticed. The disease is progressive and cure is not certain. A treating physician will decide it. Nobody else has the right to decide. If endocrinologist is treating a diabetes or his complication, only he can decide. The disease is progressive and cure is not certain. Number two, persistent symptoms despite standard care. For every disease, there is a standard protocol of the treatment. But even then, if the patient is, the prognosis is very poor, then he can refer it. Third is the psychological and spiritual distress. That is very important. The physician is treating the chronic disease, but he is not treating the psychological and spiritual distress. For this particular problem, every patient should be in touch with the palliative caregiver. Every patient, I should say, because slowly he will develop this. He gets a disease and within a span of 10 years, maybe 15 years, he may get into this problem. So he should be tracked. Fourth is the declining functional status, reduced mobility, increased dependence. If this is happening, then he should be referred to palliative care. Next is the frequent hospitalization. If the family observes that patient has to go to emergency, has to be hospitalized very often, it means that medicine which is being given by his doctor is not enough for him. Then because he is doing his best, the treating physician is giving his best effort, but even then the things are not controlling. Patient is going to hospital very frequently, then he should be taking care. And lastly, if life-limiting genetic and neurological conditions, especially in children, if this kind of patients are rare diseases are there, then also it should be referred to the palliative care unit. Need for advanced care planning and end of the life discussion. This is the aim. So first, contact is not for diagnosis and planning. Second, the role of palliative caregiver in his first visit approach to build a trust, how to behave, and what would be the objective. There are 4 things I am going to talk now. First, contact is not for diagnosis. Suppose a social worker goes to the family, treating physician has referred a case for palliative care. Now a team member, social worker, goes to his family. But he is going there not for the diagnosis. He is going there for something else. What is he going? It is not trust building. It is for trust building and understanding the whole person. His goal, the team member of the palliative care who is visiting the house of the patient for deciding what kind of palliative care has to be given, then he should trust building is the first step and understanding the whole person psychologically and physically. So only behavioral communication is needed. You understand? In the first visit, only behavioral communication. No writing, no prescription, nothing. And social worker, caregiver should be trained for communication skill. So communication skill should be there in the caregiver, and the first meeting he should apply. These are the tools: heart, nurse, pearls. These are the tools. I will come in the next slide. And then how to behave. Listen first. Compassionate listening. Let the patient and family express freely. Then gentle, respectful and calm tone. Use simple, compassionate language, avoid jargons, and sit at the eye level, never over or above the patient. Eye contact is very important when you are behavioral conversation. Respect privacy, culture and religious values. Don't force him against his privacy, culture and religious values. Very important. And the role of the PC giver to build a trust. To build a trust, I told you. How? What would be the objective? To understand the patient concern, number 1, psychologically and physically, symptoms and emotional state. At which state he is, he has to understand it. Assess the family dynamics and caregiving setup. How the family and the patient interaction is going on, that has been evaluated, and accordingly, an outside patient palliative caregiver can interact. If the family is doing wonderful, he or she can only suggest how to improve it. if he observes that the family is not taking care as much as it should be done because of their pre-engagement, then he have to decide more advanced services. Introduce the palliative care team with doctor, nurse, and counselor. So these are the team members of the palliative care. Okay, collect basic medical social history for collaboration. This is also important. He is not prescribing, he is not diagnosing, but he has to collect the data so that he can give to the doctor, he can give to the nurse, he can give to the counselor. So he is a bridge between patient and the team member, and serve as the bridge between the patient. Okay. So winning trust in palliative care. How a palliative caregiver in his first visit is going to build a trust. As I have discussed in the earlier slide, here there are three methods: HEART, H-E-A-R-T, nurse, N-U-R-S-E, and PERS. These are the first word of the tool. You see, first visit, ask yourself with HEART. HEART means what? H-E-A-R-T. Hear the story with full attention, number one. Empathize with their feelings. Acknowledge their experience and concerns. Reframe with realistic hope, and team approach. You are not alone, we are with you. So H-E-A-R-T, okay? Now you see how to implement it. Guiding questions. Am I fully listening to the patient's story without interruption or judgment? It is your feeling, right? H means here. Number two, empathize. Have I recognized and responded to their emotions with genuine care? Did I validate their struggle and show respect for what they are going through? Reframe. Can I gently shift the focus towards what is still possible or hopeful? Reframe. Because if he is hopeless, he has lost the hope. Am I able to reframe him? And last, team. Have I conveyed that they are not alone, that the whole team stands with him? So this is the HEART approach. Next is the SPIKE approach. Breaking bad news or sensitive topics. S means setup, setting, privacy and time. P means perception. What do you know so far about your disease, about palliative care? Invitation. Would you like to talk about about it now? Knowledge. Knowledge sharing small bits. E means empathize. Name the emotion and summarize and discuss next step. So this is the SP spikes. Now see how you will implement it. Have I ensured privacy, enough time and minimal interruption for this talk? What does the patient already understand about their illness? Is the patient ready and willing to receive more information right now? It's the invitation. But if he is not ready, you cannot speak. Knowledge. Am I sharing medical facts in clear, small and non-technical chunks without giving the false hope? This is important. Knowledge. Am I sharing medical facts? Empathy. Have I responded to their emotions with genuine empathy? And lastly, have I clearly summarized the discussion and explored what matters to them next? These are the responsibilities which the caregiver should give to build a trust. Now, last is the PERS, build partnership. PERS means partnership, E means empathy, A means apology, R means respect, L means legitimize and support. PEARLS, PEARLS. Principle, self-reflective questions. For participation, partnership, have I made the patient feel like we are working together as a team? Empathy, did I show that I truly understand and acknowledge what the patient is feeling? apology. Have I addressed any past care gaps or disappointment, even if I was not at all fault? Apology. Respect. Did I express genuine respect for the patient journey and the resilience? Legitimate. Have I validated that their feeling and concerns are real and reasonable? And lastly, have I assured them they are not alone and that ongoing support is available? So these three tools, heart, spike and pulse, can be applied by the palliative caregiver in the first visit. Lastly, these applications rely heavily on quality of listening by caregiver. Listening means what? Listening is not just hearing. It means slowing down, being non-judgmental, not interrupting, observing both words and body language. This is very important. And responding thoughtfully, not reactively. These 1, 2, 3, 4, 5, these 5 elements concern the proper listening. I am talking to you, you are listening, but you are not giving attention. It has no meaning. Similarly, when a caregiver go to the patient, he has to have all these qualities. Tools, I have told you, heart, spike and pulse. To heart, you must hear their story, emphasize and acknowledge their emotions. All require active listening. Spike, you must understand the patient's perception, detecting their emotional cues and knowing when to pause or proceed needs deep listening. And lastly, pulse, you cannot partner, empathize or legitimate someone's feeling unless you have really listened. So these things I have summarized it. So with these words, I end this talk, and by the take-home message, the compassion is the key of palliative care. Thank you very much.